One of the big questions of treatment nowadays is the sequencing of treatment, because we have to think after the first line. As we all know, we are not yet to the day where we are able to cure CLL with a treatment, and so we have to have a clear idea of the best sequencing of treatment. Right now, we select the patients more on the fitness and on the different comorbidities. And I think that if the patients don't have genetic resistance like TP53 mutation to chemotherapy, and if they are fit, there is no reason not to start with chemotherapy. Now we know that the BCR inhibitors are very effective in the poor prognosis patients, so it's then reasonable to start treatment. We can now avoid chemotherapy for these patients and start right away with BCR inhibitors. After BCR inhibitors, we know that unfortunately it does not cure the patients. They don't have remission for years and years, and for those who relapse, we have now the BCL2 inhibitors, and after the use of BCR inhibitors, the BCL2 inhibitors is a very good choice too. For the patients who relapse after chemotherapy, I think it's very reasonable to consider BCR inhibitors. And of course, the future right now is trying to combine in a clever way these drugs to be able to reduce the time of treatment. And we all would like to have an efficient treatment in a definite time of treatment. So that's the aim of this combination, and I think all the future trials are aiming at that.